Yes, happy to see you all. So, yesterday when I was preparing for this particular revision NEET thing, I followed all the instructions. Then I found that with the same set of instruction, already one file was there in my laptop. I was very much astonished. See, till NEET 2023, all revision questions are there. It's satisfying all the criteria given by the team. Then what should I do? I didn't understand for 10 minutes. Then only I understood that. So already I took the class of revision NEET questions at January when the exam was supposed to happen on January. So I took the document. So many of you would have listened to that document, the same lecture. So I revised all those and made it not little good, a power packed session of 1 hour. So where you could, I can bet you that this 30 pages, you will get almost 90% of the last 5 years NEET questions without any haphazard discussion, only orderly, organized discussion. Okay, I made efforts to put this all together in a proper discussion. So 1 hour, 30 pages, all questions are covered, and also you will find it in a really organized way. Okay, I'm very sure that. So this is going to be a very useful session for you. For that, I'll check that level. Yes, okay. So without any further delay, I'm already having 50 plus participants. See who overall joined this. You will find this very useful. Okay. So let me start the discussion. So I hope the audio and video, everything is good. Okay. So we'll start with this image. So we would have all had the cornetto ice cream, right? So whatever be the flavor, butterscotch, strawberry, chocolate, whatever be the flavor, but the last piece is the happy ending. Okay, so we all crave for this. No, similarly, this class is going to be like this grouping of all the happy ending questions in ENT. So you will believe it out me or not. I'm just going to discuss only 10 topics, around 5 to 7 minutes for one topic. Okay, so at the end of the 10 topic discussion, you would have covered 37 high yield last 5 years NEET questions. And also only 10 topics you would have discussed, but you would have covered at least 25 to 30% of ENT. Okay. Without further delay, we'll start the discussion. The first topic I would emphasize is anatomy and embryology of the ear. We got 5 questions from this particular chapter from the last 5 years NEET questions. So first question is, from which of the following structure does the saccule develops from? If you know the answer, you could keep answering. Okay. Or else you just listen to what I'm saying from the discussion point of view. So this was a NEET 2030 question. I will just give you some glimpse about the embryology part of the ear. First, the external and middle ear develop from the pharyngeal arches, except stapes footplate. Okay, whereas the neural ectoderm by 4th to 5th week of gestation develop into otic capsule, otic vesicle. See here, this otic capsule develops into bony labyrinth and stapes footplate. This is the reason otosclerosis will affect only the stapes footplate and bony labyrinth, but not the other part of the ear obstacles. Otic vesicle develops into membranous labyrinth. Okay, these all you know very well. Now, what is the next line of discussion? This otic vesicle further divides into pars superior and pars inferior. Okay, pars superior, pars inferior. So this pars superior, CSU, semicircular canal atricle. Okay, don't confuse this A. Then the pars inferior, saccule and cochlear duct. Then the cochlea will develop further turns by 8th week of gestation. All MCQ, all are MCQs. The interscalar septa will appear at the level of the 22 to 23 weeks of gestation. So the answer for this question is, so saccule develops from pars inferior. Saccule develops from pars inferior. Next question. So iron for the board. So NEET 22 question. See, I've always told you malleus, incus always looks little bit same from each other. So how can you identify? Simple trick. See, a round prominence and a small neck, then a body like this. If it looks like a hammer, this is malleus. If the tip is little bit flat and there is no neck-like structure, it is incus. Because they will ask the cadaveric image, please be sure about that. So the step is a stirrup shaped. Incus is a anvil shape. This one is a hammer shape. So what is so important? This manubrium is making contact with tympanic membrane. Okay. The short process of incus is forming contact with facial nerve in the form of fossa incudis. Very, very important point. This is useful. Fossa incudis, short process of incus, facial nerve relation. And also least blood supply. This is having least blood supply. So more prone for erosion. More prone for erosion. This is going to be a rapid discussion. Please don't divert yourself. Then malleus is having the muscle of tensor tympani. So tensor tympani originates from the anterior wall, canal for tensor tympani, then further takes a groove from the process cochleariformis from the medial part of the middle ear, then finally attached to the malleus. So tensor tympani muscles gets attached to the malleus, whereas stapedial tendon, the muscle of stapedius, gets attached to the stapes. Stapes originates from pyramidal eminence over the posterior wall of the middle ear. Pyramidal, the posterior wall of the middle ear. Very, very important points only. I'm just telling to you people. Okay, fine. So with that, now we can enter into the next question. The answer for this question is incus. Okay, this is a incus. NEET 2022 question. Then some quite challenging question. Okay, now a person with high frequency hearing loss, affected area close to. What is the answer for this question? You keep answering. Okay, if you know the answer, you could keep answering. Okay, I will also continue my discussion. See here, this cochlea. If you look into this cochlea, the center point you always start with A. I always do like this. If you have any confusion, which is apex, which is base, so this is the apex. This is the base of cochlea. The base of cochlea is supposed to be important for high frequency sound conduction, whereas the apex is for low frequency sound conduction. Which means that if we start from 100 decibel over here, 100, 500, 1000, 2000, 4000, like this, if we plot the different frequencies along the course of the cochlea, so this base will be the area where there will be high frequency sounds. So when we have high frequency sounds, this apex will be inside to the inner ear, whereas the base will be closer to the oval window and round window. Okay, oval window and then round window. So indirectly what they are mentioning, high frequency hearing loss is closer to the base, and also high frequency hearing loss, this base is closer to which structure? So what is the stria vascularis? It is an area for origin of endolymph. So it is not found anywhere closer to the base. This modiolus is the base, is near to apex. Modiolus is near to apex. Helicotrema is in the midway. Helicotrema is this is the area where we could see the helicotrema is at the midway. So which is closer to the base is the oval window. Okay, which is closer to the base is the oval window. Why no one has? All of you have answered this question? Yes, mostly have answered. I think. So the answer for this question is. So we have discussed about something about the embryology, middle ear anatomy. I have told you something. Then inner ear anatomy. So this is a inner ear anatomy. So I will tell you other inner ear anatomy also. See here, I am dividing the cochlea into scala vestibuli, scala media, and then scala tympani. The scala tympani and the scala vestibuli will be filled with fluid called perilymph. Okay, whereas this scala media will be filled with endolymph. That is the most important point. Okay, so scala media will be filled with endolymph, whereas scala vestibuli, scala tympani filled with perilymph. Okay, so with that note, what about this point, sir? What is the significance of scalar tympani? We answer this question. Where is the electrode of the cochlear implant placed? This is a question. So for understanding this question, you should know the inner ear anatomy also. So answer this question, please. So where is the electrode of the cochlear implant placed? Can you please answer? Yes, keep answering. So with that particular point, cochlear implant, we could revise a bit about the hearing devices. So hearing devices, I would broadly classify the hearing devices into two types. One is amplification device. The next one is substitute device. Okay. So basically, hearing aids are amplification device. The implants are substitute device, which means that the answer for this question is the cochlear implant is placed to the scalar tympani. Okay, so I will elaborate upon this particular point. Okay, further. First, what is the classification of hearing devices? It could be an amplification device. It could be substitute device. So all of them are concerned with sensory neural hearing loss. All the hearing devices are mainly for sensory neural hearing loss. It is not for conductive hearing loss. The conductive hearing loss, I'm having a problem over the external ear. I'm having a problem over the middle ear. The only conductive hearing loss which I'm going to have is this one. Only device for conductive hearing loss is this device. What is the name of this device? Yes, Dr. SS, you are spot on. Baha. What is Baha? It is not Aha. It is Baha. It is bone anchored hearing aid. So please look into this particular question. So this hearing devices, I could use it for amplification. It's nothing sort of a speaker. So for example, old age people in our home, if they don't hear properly, what they will do? They will increase the sound in the TV. So this hearing aid is nothing but a speaker setup which is amplifying the natural sound. Whereas this implant, when the particular part of the inner ear, not the entire inner ear, if the particular part of the inner ear is not working, it is acting as substitute ear for that particular part. Okay, so that's the first point. Then hearing aids are divided into two types. One is conventional hearing aid. The second one is bone anchored hearing aid. The conventional hearing aid can be done only if the ear canal is normal. The Baha can be used if the ear canal is abnormal. Ear canal is abnormal. See here, what are the conditions where ear canal will be abnormal? Point number one, if the patient is having external auditory canal atresia, the ear canal can be abnormal. Point number two, if the patient is having a CSOM with canal, so CSOM, prolonged CSOM, the patient can't hear properly. Then the patient is having mixed hearing loss in CSOM, you could use a Baha. So this through the ear canal, this behind the ear canal, this is through the air conduction mode, this is through the bone conduction. So whatever be the conduction, the ultimate aim is amplification of the sound. Now, with that note, we know something about external auditory canal atresia. So what is the surgery we could do for external auditory canal atresia? Surgery for external auditory canal atresia. Now, can you understand how I derived 37 questions from only 10 topics? I have intermatched all the topics in a systematic way. See, within the topic, I have grabbed almost many important topics. The surgery for external canal atresia is canaloplasty. That is the point I need to stress. I am connecting external canal atresia with another topic called canaloplasty and meatoplasty. Okay, so modifying the bony part of external canal is called canaloplasty. Now the question is not canaloplasty. It is about the surgery done to widen the cartilaginous part of external canal. It is called as meatoplasty. Now let me explain you people. Yes, meatoplasty. The meatoplasty is not only for 6 years, Dr. SS. Meatoplasty can be done for any patient who is undergoing modified radical mastectomy. It is not based on age. Okay, you would have seen some books referring to age. Yeah, you could do it. Just they are mentioning that modified radical mastectomy you would not usually do less than 6 years because the cartilage would not be extensively formed. So modified radical mastectomy you will do after 6 years only. So that is the point you need to understand. It's not that meatoplasty should be done 6 years, canaloplasty 7 years. Not like that. Meatoplasty is done as a part of modified radical mastectomy. You just look into this picture. This is the cartilaginous part of the external canal. This is the bony part of the external canal. See, doctor, I am doing a modified radical mastectomy where I am removing all the mastoid air cells. I am removing the posterior part of the canal wall. So while removing the posterior part of the canal wall, if this cartilage remains as it is now, it will cause pinna deformity and it would cause some perichondritis after surgery. To avoid those complications, what I am doing now, I am going to remove only the cartilaginous part of the bone. You may ask me whether we are removing bony part, posterior canal wall we have already removed. Okay, the definition of modified radical mastectomy itself is removal of posterior part of the bony canal. Now, this is not removed per se. So, we are removing at the end of the procedure. That procedure is called meatoplasty. Modifying the cartilaginous part of the external auditory canal is called as meatoplasty. It is not done separately. It is done always as a part of the procedure called modified radical mastectomy or canal wall down mastectomy. Okay, that is the point you need to understand. Now, canaloplasty on the otherwise, it is not done as a part of another procedure. It is done ubiquitous. It is done separately in case of external auditory canal stenosis or atresia. Okay, so if this part is stenotic, and also you could do for external auditory canal osteoma or exostosis. So if there is bony overgrowth over the external auditory canal, you could do this procedure of canaloplasty. Okay, understood? Say I'm connecting the dots, one topic to another topic, but at the end of the day, we are almost solving all the last 5 years question. Okay, so with that note, hearing aid, we are using conventional hearing aid. We can use bone anchored hearing aid. Both will amplify, one through the air conduction, one through the bone conduction. Now, this middle ear implant, I will come otherwise. Now, let me explain about the cochlear implant. See here, cochlear implant is placed through the facial recess behind the ear by posterior tympanotomy approach, then through the round window, then into the scalar tympani. All 3 words you should remember. Behind the ear, I am approaching the middle ear through the facial recess. This facial recess, I have already told you, it is formed by facial nerve, chorda tympani nerve, and then short process of incus. Okay. So facial nerve, chorda tympani nerve, and short process of incus. These are the boundaries of the facial recess. If we reach this particular place, we could enter into the round window. If we enter into the round window, we could enter into the scalar tympani. Okay. So this is the points you need to understand about cochlear implant. So cochlear implant can be done in case of Mondini's dysplasia, congenital deafness with normal cochlea, affected hair cells. So this cochlear implant can be done only if hair cells are defective. So it should have congenital deafness with normal cochlear nerve. Normal cochlear nerve. You may ask me, sir, is there some problems where there could not be a normal cochlear nerve? Yes, there are lots of anomalies such as Michael dysplasia, where the both bony labyrinth, membranous labyrinth not formed properly. Bing-Siebenman anomaly. These are just examples, pa. You don't confuse yourself. Bing-Siebenman anomaly. And then bilateral neurofibromatosis causing bilateral vestibular schwannoma after doing surgery. After surgery for bilateral vestibular schwannoma. So we are removing the vestibular part of the vestibular cochlear nerve, which means that cochlear nerve also getting damaged. So we could bypass it and enter into the brainstem. So these are the indications for brainstem implant, Michael's dysplasia. Bing-Siebenman, and apart from the Mondin's dysplasia, all other dysplasia, we could have 4 dysplasias: Alexander dysplasia, Sheeby's dysplasia, Michael's dysplasia. So apart from Mondin's dysplasia, whatever dysplasia that you come across, those are indications for brainstem implant. Those are not indications for cochlear implant. Cochlear implant, only Mondin's dysplasia. Okay. So bilateral vestibular schwannoma after doing surgery, we would have lost the cochlear nerve. In those conditions, we could use a brainstem implant. Where is the area where we are going to introduce the brainstem implant? It is introduced into the lateral recess of the fourth ventricle. It is introduced in the lateral recess of the fourth ventricle. Okay. Understood, pa? Yes. So now we have seen about hearing aid, which is conventional bone anchored. Then implant, cochlear implant with brainstem implant. Now let me introduce a different topic. A new question you may be asked from this particular implant because it has been in circulation over the last 7-8 years, but they have not asked question from this particular topic. Kindly make note of this. Middle ear implant is nothing but an implant where I am implanting a vibrating sound bridge. Vibrating sound bridge into ear ossicles. So this is a hybrid model like petrol and electric car. Similarly, this is an implant where I am going to introduce an implant into not the inner ear, into the middle ear, but it will only amplify the sound. It is not a substitute like cochlear implant or brainstem implant. So it will amplify. So it is amplify. So to be precise, it is better than hearing aid. It is less than cochlear implant. This middle ear implant is better than hearing aid, but is less than cochlear implant. Okay. So it is a latest advancement. We are just introducing a vibrant sound bridge. So this sound bridge will receive the sound from the atmosphere and it will amplify the ossicles. If ossicles are directly amplified, means you just imagine the quality of the sound. It will be very good quality. For that, we have found out this. But surgery is very cumbersome. It has been not done routinely in India. It has been in practice over the Western countries. India, it costs around 4 to 5 lakhs. So we are not doing this. They may ask this MCQ. Which is the most common ossicle? You could say incus or stapes suprastructure. These are the most common ossicles where middle ear implant is routinely done. Okay, fine. So that note, we have solved almost 5. And also from this particular subjective asking also ask this time also 2 tests and then 24 tests. So first one is Rinne's test. If air conduction better than bone conduction, Rinne is positive, seen in normal patient or sensory neural hearing loss. Bone conduction better than air conduction, it is Rinne is negative, it is in conductive hearing loss. It's as simple as that. Weber's test. If it is lateless to the better ear, it is sensory neural hearing loss. It is lateless to the affected ear, it is conductive hearing loss. Why it is lateless to the affected ear in conductive hearing loss? Because this is the atmospheric effect. Normally, this bone conduction is always interfered by the air conduction. But if there is a conductive hearing loss, some CSOM, this bone conduction is not interfered by the air conduction. So for that reason, it is lateless to the affected ear rather than the better ear in conductive hearing loss. Very, very important point. Lateless to affected ear, conductive hearing loss, you should always remember. So which is the most sensitive 24 test? Weber's test. Which is the test? So even 3 to 5 decibel difference can be found out. Okay. Most sensitive test. And also the best test of choice is Weber's test. Okay. So with this, you could perfectly diagnose whether it is a conductive hearing loss or it's a sensory neural hearing loss. Okay. Fine. Next one is absolute bone conduction test. See, absolute bone conduction test, we should close the tragus of the patient You place the tuning fork over the master process. Ask the patient. You raise your hands once you stop hearing. The patient raised the hand. After the patient raises hand, you place the tuning fork over your master process after closing the tragus. If you still hear the sound even after the patient stops hearing, which means that the patient hearing is diminished, your hearing is normal, reduced than the examiner, it is inference is sensory neural hearing loss. Okay, so you know this very well. Rene Weber, observed bone conduction. If you don't close the tragus, it is called Schwaback test. Okay, but observed bone conduction, closing the tragus is the commonest done test. Okay, fine. Now, so with the tuning fork test itself, we could find out whether it's a mild, moderate, or severe hearing loss, correct hearing loss. So negative Rene for 256 Hz frequency, mild hearing loss. Negative Rene for 256 and 512 Hz frequency, it is moderate hearing loss. Negative Rene test for all three tests, it is severe hearing loss. Okay, sir. How can we grade whether it is the same WHO classification for hearing loss? So it's not the same because the WHO classification is mild, moderate, moderate is severe, then severe. Here they have directly given mild, moderate, severe. So you just write it down. For mild hearing loss, the tuning fork test, you could understand it to be 15 to 25 decibel. Moderate, 25 to 40 decibel. Severe, more than 45 decibel. You please write it down. So with this note, we could answer one MCQ. So 24 years female person with hard of hearing. She underwent tuning fork test which showed negative Rene for 256 Hz and 5 Hz frequency. And so 15 to 20 is only 256 Hz frequency. Okay. So we are having 256 and 512 Hz frequency, this one. So some are saying it to be 45 to 60, some are saying it to be 30 to 45 decibel. So for me, both can be correct. For me, both can be correct. But the best answer is 25 to 40 decibel. Okay. 25 to 40, 45 decibel is the best answer. So this is also having 45, this is also having 45. Okay. So this is intermediate question. Okay. I can't say this is correct, this is correct. This was asked last time. Okay. So you just make sure that 25 to 45 decibel is the correct option. So if they ask this time 25 to 45 decibel, you better answer that. If not, I would say both can be correct. This or that you could take it. Okay, this or that you could take it. Fine. So this is for severe. This is for severe. This is for mild. No doubt in that. Okay. Fine. So I hope it helps. Okay, it's quite a controversial question. I can't help that. But if the options are given like this, you could answer it correctly. Fine. Next, audiogram. So I've already told my batch the 3 thumb rules for plotting the audiogram. You don't jump directly into the airborne gap. The thumb rule number 1 is if there is any curve more than 25 decibel mark, it is hearing loss present. If the bone conduction curve alone more than 25 decibel mark, sensory loss present. Then you look into the airborne gap, whether it is more than 10 decibel conductive hearing loss, less than 10 decibel sensory hearing loss. Okay. Let us apply all these in the audiogram curve. So audiogram curves basically broken lines means bone conduction curve. Then red color for right side. Red color for right side. Blue color for left side. Broken lines for bone conduction. Continuous lines for air conduction. Broken lines for bone conduction. Okay. Now look into this audiogram. So what is the audiogram saying? So what is thumb rule number 1? This is the 25 decibel mark. Can you see, pa? This is 25 decibel mark. What is thumb rule number 1? Any curve more than 25 decibel mark. See, in the audiogram, you should read from above to below. This is 0 decibel, 10 decibel, 20, 30. Above to below, you should read. Thumb rule number 1. Any curve more than 25 decibel mark. Please answer. 150 participants are there. Please answer. The first point is any curve more than 25 decibel mark. Tick. One curve is more than 25 decibel mark. Answer. The hearing loss is present. The second thumb rule. The bone conduction. See the bone conduction curve more than 25 decibel mark. Whether it is there? No. It is not there. Can you see, pa? Can you see clearly? 20 decibel. It is only 20 decibel. This broken lines is not more than 25 decibel. The third point, airborne gap. A, B gap. See here, it is more than 10 decibel. Which means that it is confirmatory of what hearing loss? Please answer. It is confirmatory of right sided. This is a red colored curve, right sided. So Hari Narayana, see the airborne gap is more than 10 decibel pa. This is not sensor loss. It is right sided conductive hearing loss. I will repeat it. The point number 1, it is having more than 25 decibel, at least one curve. The point number 2, the bone conduction curve is not more than 25 decibel, which means that sensor loss is not present. The point number 3, the patient is having airborne gap more than 10 decibel. It is right-sided conductive hearing loss. Why right-sided? Because red colored curve is there. Okay, we'll enter into, see, this is right-sided conductive hearing loss picture. Now, look into this particular picture. You again come with me. What is the first point? This is the 25. This is the 25 decibel curve. Point number 1. Any curve more than 25 decibel, you put a tick. Yes. Point number 2. This is broken lines. This is broken lines. So bone conduction more than 25 decibel, you put a tick. Sensor loss is present. Now you straight away don't jump into this is a right sided sensor hearing loss. You should confirm it with the third point. What is the third point? Airborne gap. The airborne gap is less than 10 decibel. Can you look into this? This is the airborne gap which I am talking about. It is not more than 10 decibel. It is less than 10 decibel, which means that it is confirmatory of. It is confirmatory of. Yes, come on. It is confirmatory of red colored. So it is right sided sensory neural hearing loss. You should always apply these 3 thumb rules. If you don't apply, you may go wrong. Okay, I will demonstrate how it will go wrong. You just look into this picture. If you look into this picture and you arrive at a spot diagnosis, you will go wrong. So you should always apply my 3 thumb rules. See here, both curves are more than 25 decibel, which means that hearing loss is present. Point number 1. Point number 2, bone conduction curve is more than 25 decibel. Tick. Sensor loss is present. Tick. Okay. The third point, airborne gap is more than 10 decibel. Airborne gap is more than 10 decibel, which means that conductive hearing loss is present. So what is the diagnosis is? Yes, Dr. Nandini, you are correct. Please, others come with the answer. Yes, it is correct. It is a right-sided mixed hearing loss. Now, can you understand why I'm stressing too much on 3 thumb rules? So if you straight away jump into airborne gap, you will miss the mixed hearing loss. You should not do that. So you should apply these three thumb rules. Then only you will arrive. It's a right-sided mixed hearing loss. Most of you answer correctly. What are the special audiogram findings? So Karat's notch, 2000 Hertz bone conduction dip. Bone conduction dip is Karat's notch in otosclerosis. 4000 Hertz, both bone conduction and air conduction dip. Noise-induced hearing loss. If it is a low frequency rising curve, it is Meniere's disease. If it is a high frequency sloping curve, it is age-related hearing loss or presbyocusis. Cookie bite pattern, middle range frequency like this, it is congenital deafness. Okay, with this note we can solve this MCQ. Okay, so Karat's notch, noise-induced hearing loss, rising curve is Meniere's disease, sloping curve is age-related hearing loss, cookie bite pattern is congenital deafness. So 55 years woman complains with tinnitus, progressive hearing loss, vertigo. This is the audiogram. So what is this audiogram? What is the diagnosis? This question was asked last time before time. What is the diagnosis? What is the audiogram picture? What is this audiogram picture? What is the diagnosis? This is low frequency rising curve. It is seen in Meniere's disease. It is seen in Meniere's disease. So among the options, so cochlear otosclerosis is a conductive loss, vestibular neuroma. It is a retrocochlear deafness. You will not get this picture. Noise-induced hearing loss, 4000 Hertz dip. These are not seen over here. It's an endolymphatic hydrops, otherwise called Meniere's disease. Okay, it's a clear-cut picture of Meniere's disease, or otherwise called endolymphatic hydrops. Only with the audiogram picture you could come out with the diagnosis, because tinnitus, vertigo, hearing, progressive hearing loss can also be seen in vestibular schwannoma. Okay. So you should not come out with the diagnosis, because audiogram is very, very important. Okay. So it's always glaucoma here. Your great doctor degree is correct. So next we jump into nose. A patient presents, it's an easy topic, atrophic rhinitis. There are 2 questions. A patient presents with mercible anosmia, foul smell discharge, occasional epistaxis. What is the finding? Please answer this question. I'll jump into the discussion part. So, atrophic rhinitis, otherwise called ozane, it is caused by Klebsiella ozane. What is the theory? If there is an unhygienic nose invaded by the bacteria, and also there will be deficiency of vitamin D and estradiol. Okay, estradiol. Okay, sir, what is the presentation? So, merciful anosmia, foul smelling, greenish discharge, occasional epistaxis, and then roomy nasal cavity. These 4 are the presenting symptoms. Okay, so you just write it over here. It's very easy. You don't have to write at all. So these are the 4 cardinal features of atrophic rhinitis. Okay, sir. What is the medical management? Medical management, we could do nasal douching with chemicetin anti-ozane solution. Chemicetin anti-ozane solution. It is also called anti-etiological solution. It will comprise of estradiol, vitamin D, and then antibiotic against the bacteria, fluorophenical. So this is the most commonly used solution where you'll be having estradiol, vitamin D, chloramphenicol. Okay? Yes. So partial closure is done in which condition? Partial closure of nostril. Then which condition? Is again atrophic rhinitis. See here. What is the surgical management of atrophic rhinitis? See, it's very clear. If the nose is open, the air entry for bacteria increases. The bacteria will thrive further. If we close the nostrils, the bacteria will die. Okay, the bacteria will die. The partial closure of both nostrils is called modified Young procedure. Modified Young's procedure. So partial closure of both the nostrils. So complete closure of one nostril. Complete closure of one nostril. It is called as Young's procedure. So Young's procedure, what is the difference between Young's and modified Young's? You completely close one nostril, Young's. You leave some gap between both the nostrils. You close both the nostrils, some gap between, it is modified Young's. Okay. We are nowadays doing only modified Young's, where we leave a small gap for breathing of the patient and also. Okay, fine. So next topic from rhinology. It's an amalgamation of radiology and sinusitis pathology grouped together. You will not see anywhere like this in the workbook and all. It is a super amalgamation of all the important topics grouped together. The first one is in sinusitis. Most important thing you need to know is radiology picture. Radiograph shown is a occipitomental view with open mouth. What is the other name of this view? Answer this question, please. So this is a Waters view or occipitomental view, or you could also call it as Pieris view. In the option, if you see Pieris view, that is the best answer. In the option, if you see Waters view, that's the second best answer. Then occipitomental view is the third best answer. Okay, the best answer is Pieris view. In this option, it is not given Pieris view. So the best answer for in this question is Waters view. But if they ask Pieris view, that is the best answer. Okay, so Pieris view is the best answer. But in this question, Waters view is good. So this view, you could see all the sinuses: frontal, ethmoid, maxillary, and then sphenoid sinus. All 4 sinuses. So which radiological imaging best for visualizing all the sinuses? It is Waters view or Pieris view. Okay, fine. So Waters view is used to obtain diagnostic information of which sinus? Please answer the question from NEET 2018. It is yes. Yes. Please answer. So which is the biggest sinus here? Maxillary sinus. So the maxillary sinus radiology will never go wrong. It is a maxillary sinus. So this is a Waters view, occipitomental view. Okay. So where you see all the 4 sinuses. What is the Caldwell's view? It is an occipitofrontal view. It is best suited for frontal sinuses. It is best suited for frontal. Can you see here? This is an occipitofrontal view or Caldwell's view. This could also you can ask us question. So frontal sinus. What is the next view? Townes view. It's an anteroposterior anterior cranial fossa view. Anterior cranial fossa view. So what is the significance of this? See here, I could see the masted cells. I could see the anterior cranial fossa. If there is some tumor, I could diagnose it. Okay. So a lot of structures can be visualized with this. It's a town. You are the Spider-Man. Sit at the top of the town. You're looking the entire town with your bullseye view. So you just think of Townes view like this. You are viewing the ear, nose, anterior cranial fossa entirely. That is called Townes view. Okay. It is a anterior posterior view. Viewed from the front, it is viewed the entire anterior fossa. Fine. So this table very important. You will never see this table in any book. Okay. So it's an amalgamation. How you should find out the difference between a bacterial sinusitis and a fungal sinusitis. See, bacterial sinusitis mostly caused by gram-positive bacteria, staph, strep, haemophilus, whatsoever. But fungal sinusitis can be caused by a large group of fungus. It is divided into first non-invasive and invasive. Non-invasive can be only fungal ball. Okay, it will mainly affect the maxillary sinus and then sphenoid sinus. Then it could be allergic fungal rhinosinusitis. It is given by Bent and Kuhn criteria. So what is the difference between these two? See, once spore has entered into the maxillary sinus, it is forgotten. It will slowly grow. It will form a ball. The patient will find out the maxillary fungal ball only after some 5 or 6 years. So it will cause some pressure symptoms. Whereas allergic fungal sinusitis, you are working in a farm or your house is filled with some fungal spores. So you keep on exposing to the fungal spores. The fungal spores will enter into the nose. It will settle down at some of the sinus. So it will cause growth of the spores and also it will cause some allergic response then and there. So spores also growing, allergic response creating some allergic mucin getting settled into the sinus similar to the bacterial sinusitis is also happening. Okay, sir. This is allergy. In bacterial sinusitis also, allergy can cause some symptoms. How can we differentiate? We could differentiate beautifully with the help of the imaging. CT-PNS. In CT-PNS, you will see a homogeneous, equal. All where the air fluid levels are equal. Homogeneous opacity. Whereas you look over here, this one where different. So different heterogeneous opacity is a pathognomonic for fungal sinusitis. In bacterial sinusitis, a homogeneous opacity like this. In fungal sinusitis, heterogeneous opacity like this. So that is the clinching point. In the question, they will definitely give an imaging study. With the imaging study, you should find out the diagnosis, heterogeneous opacity. So for all the sinusitis, be it non-invasive, invasive, aspergilloma, mucormycosis, whatever be the fungal sinusitis, always it will have heterogeneous opacity. Bacterial sinusitis with polyp, without polyp, whatever be the cause, it will be homogeneous opacity. So this is an antrogonal polyp only. Sinusitis with polyposis, but it is having only homogeneous opacity. Okay, sir. The treatment wise very different is, if you are having a patient with bacterial sinusitis, chronic sinusitis, you could give oral antibiotics, steam inhalation for 1 or 2 months. You could wait and watch for medical management. FES, which is a surgical treatment done only in unresponsive cases, whereas medical management alone is never a treatment in fungal sinusitis. Very different point. You would have missed this point. Why? Because here giving antifungal is suicidal. Giving antifungal for fungal ball, never a cause. Because it is non-invasive. If you give the antifungal into the blood, it will not reach over there. You should do surgical excision for this. You should do surgical excision for this. You should do surgery for this. You should surgery with amphotericin for this. Only in invasive mucormycosis, you should give amphotericin also. Rest to all the fungal sinusitis, whatever be the cause, you do FES surgery as early as possible. Very important points. Some 10 MCQs are packed over here. So very important point. With this note, we could solve some 2 MCQs from the sinusitis chapter alone. 55-year diabetic, loosening of teeth, hemifacial pain, COVID-19 infection. During COVID-19 area, we saw a lot of mucormycosis, black fungus cases. Okay, so it is nothing but mucormycosis. My question is, you should confirm the mucor with a nasal swab. If the option is nasal biopsy, that would have been the better option. So nasal swab or mucor. You may ask me, MRI brain web, whether we could take, sir. So I could still say, compared with the nasal swab and MRI brain, nasal swab is the best answer. Okay, but instead of nasal brain, if they have given MRI PNS means, so out of these three things, nasal biopsy is first. This is the best investigation. So nasal swab and MRI PNS, you could give some equal priority because it has already confirmed with few of the clinical features, but the documentation purpose. So if you took biopsy and confirmed it, the second best is MRI PNS only. So with this note, first you should think of some swab or biopsy. Then you should look for MRI, that too MRI PNS, not MRI brain. So for this, the best answer is nasal swab or mucor. Okay. So another question from sinusitis. So sinusitis with polyposis, a question. A middle-aged male, rhinorrhea, asthma, nasal polyp, then diagnosed to have Santos triad. Which of the following should be avoided? Santos triad is having three triad of aspirin insensitivity, asthma, nasal polyp. It's a very easy question. You know very well. Then the gold mine of MCQs, gold mine of concepts, very high yield topic is nasopharynx. So if you understand anatomy nasopharynx, if you understand three diseases nasopharynx, you are definitely solving one MCQ. Okay. So what is nasopharynx? So this area is a nasopharynx, which I'm talking about behind the nasal cavity. This is the nasopharynx. Okay. So the anatomy of nasopharynx very, very, very important. So this is the posterior wall. This is the lateral wall. This is the inferior aspect. So anteriorly we are seeing this. Okay. Now what are the boundaries of the nasopharynx? So easy points. Roof is skull base. Yes, of course. Posterior wall. Behind it, you will see a vertebra. Yes, of course. Lateral wall, very, very important. Yeah, what you would see in a lateral wall? The point number 1, this is a fossa of Rosenmuller. Point number 2, this is torus tubaris. Point number 3, it is eustachian tube opening. So what are the three structures? Fossa of Rosenmuller, torus tubaris, eustachian tube opening. So anteriorly you will see the nasal cavity. Inferiorly you enter into the oropharynx. Okay. Now with that note, we'll solve this MCQ. So the MCQ gave arrow mark over here. Okay. Now we answer this MCQ. Identify the area nasopharynx behind the elevated part of the lateral wall. What is the answer for this question? Please answer. It is. Please answer. It is fossa of Rosenmuller. Okay. Fine. Fossa of Rosenmuller. Okay. Fine. Then we are having three diseases in this particular nasopharynx. One is JNA, one is Castleman nasopharynx, another one is adrenal hypertrophy. The first one is JNA, juvenile nasopharyngeal angiofibroma. It is seen in adolescent males. So 12 to 16 years male coming to the recurrent epistaxis, profuse epistaxis. Okay, you think of JNA. So this JNA is a benign encapsulated tumor. Okay. So it will cause profuse epistaxis, nasal obstruction, frog face deformity. What is the commonest site? The commonest site of this is sphenopalatine foramen. The hormone that is thought to play a role in JNA is testosterone. CT facial bone, it will show pushing of the posterior wall of the maxilla. It is called Coleman-Miller sign. The treatment, surgical excision can be done, and radiotherapy is indicated only if there is intracranial extension. So all are high yield points. Okay, fine. A question from this particular thing. 18 years male, recurrent epistaxis, nasal obstruction since 1 year. What is the diagnosis? It is of course juvenile nasopharyngeal angiofibroma. Okay, so it's a NEET 2022 question. So epistaxis and all, if you come across 18 years male and all, it's definitely case of JNA. Okay, as simple as that. So carcinoma nasopharynx. So carcinoma nasopharynx is a malignant tumor. It is a carcinoma. What is the etiology? It could happen in a Chinese Epstein-Barr virus is the cause. HLA-B7 can be the cause. The commonest site, fossa of Rosenmuller. I showed you, lateral wall is having fossa of Rosenmuller. That fossa of Rosenmuller is the commonest site for carcinoma nasopharynx. What is the clinical presentation spread? In which it could enter into the same spread patterns: superior, skull base, posterior vertebra. Then laterally it can enter into the eustachian tube causing conductive hearing loss. Entering into eustachian tube causing conductive hearing loss. So that will cause serous otitis media. The patient with carcinoma nasopharynx will be having a ear symptom called conductive hearing loss and serous otitis media. The type of tympanometry graph in carcinoma nasopharynx is, please answer. What is the tympanometry or impedance audiometry graph seen in carcinoma nasopharynx? Please answer. What is the type of curve? It is a impedance audiometry flat curve. What is the curve is called as? It is a B curve. A flat curve seen on impedance audiometry is called as B curve. Okay, it is not AB curve, it is only B curve. Okay, AS curve otosclerosis, AD curve ocular discontinuity, C type of curve eustachian tube dysfunction. Okay, so it is a B type of curve. So we have already asked about Samter stride. So they may ask Trotter stride also. What is Trotter stride? It is seen in carcinoma nasopharynx spreading into sinus of Morgagni. Okay, sinus of Morgagni, if it is filled with a tumor, it can cause temporoparietal neuralgia, palatal palsy, and conductive hearing loss. These are the features of Trotter stride. How it will occur? If the tumor enters into sinus of Morgagni, which is found between the skull base and superior constrictor muscle. Okay, fine. 70 years male with neck nose examination reveals dull tympanic membrane type B curve. Answer is nasopharyngeal carcinoma. Okay, so we are solving an ample amount of MCQs. I am not any new MCQs. These are all asked from last 5 years NEET only. Okay, fine. Adenoid hypertrophy. So the third important disease of the nasopharynx is adenoid hypertrophy or nasopharyngeal tonsil enlargement. So a 10 years old child coming to the OPD with the following facial feature. It is nothing but adenoid facies. So how adenoid gland is nothing but nasopharyngeal tonsil lined by ciliary pulmonary epithelium. A chronic nasal obstruction and the mouth breathing leads to characteristic appearance called as adenoid facies. So how can you find it as adenoid facies? See here, the child is having crowded maxillary row of teeth, loss of nasolabial fold, open pursed lip, this mouth is a little bit open, then dull expressionless face. So these are the features. So high arched palate, crowded maxillary row of teeth, loss of nasolabial fold, pinched up nostril, sunken eyes, high arched palate, pursed lip breathing, elongated face, short upper lip, hyperplastic. These are all the features of adenoid facies. They have asked questions from adenoid facies. So they ask any of these options. So that just by I've kept all the 9 characteristics of adenoid facies over here. So next question, common for adenoid hypertrophy and also carcinoma nasopharynx. 6 years old boy, 2 months of diminished hearing, and his mother took him to hospital. Otoscopy reveals this picture. So it may be a question from here, but what is the cause? This is a cause of adenoid hypertrophy. This child is having adenoid hypertrophy. This adenoid hypertrophy is causing serous otitis media or otitis media with effusion. Okay, this adenoid hypertrophy is a diagnosis for this condition. This adenoid hypertrophy is causing this SOM or OME. Okay, so this how I have framed the question. Can you understand? So this is a year question, but what is the cause for this year question? This is nasopharynx. So they're asking question from nasopharynx, be it the diagnosis is OME or the otherwise, but they're asking from nasopharynx. That is the most important topic here. Next, what is the anatomy of tonsil and tonsillar diseases? Of late, over the last 3 years, they are asking lots of questions from tonsils also. The tonsil, what do you need to know? First, the blood supply of the tonsil. Descending palatine artery from maxillary artery, ascending pharyngeal artery, ascending and tonsillar branches from facial artery, ascending palatine. Okay, ascending palatine and tonsillar branches from facial artery, and tonsillar branches from lingual artery. Okay, so these are the branches of the facial tonsils blood supply. Why I am telling this? Because they have asked some hemostasis question, post-op question last year. So they may ask which is the commonest artery that would have caused it. So the question is, if the patient is undergoing a tonsillectomy, profuse bleeding is facial artery. Profuse bleed. We could think of tonsillar branch of facial artery. Whereas commonest bleed is due to paratonsillar vein. Paratonsillar vein. The only venous supply over here is paratonsillar vein. The commonest cause of bleeding is paratonsillar vein. The cause for profuse bleeding is tonsillar branch of facial artery. Can you understand this? The question is this. What is the question they asked? This is the question. Okay. Okay. The patient has undergone tonsillectomy. So after tonsillectomy, I could see a peroral bleed after 2 hours. Like clots were present. Okay. Now, you should watch for some of the important points. Peroral bleed, okay. Only clots are present, okay. So, instead of clots, if on examination, if you could see frank blood with repeated swallowing, if these points are given in the question, without any doubt, the answer should be shift the patient to OT and ligate the vessel. Shifting the patient to OT and removing blood clots is never done, because if you are shifting the patient to OT, only for removing the blood clots, we would not do the procedure. So this is never an option. Okay. Now, only blood clots are seen. No frank blood is seen. No repeated swallowing. I would say this can be. I would say this can be the correct answer. But some faculty are saying this could be the correct answer, but depending upon the question, I will tell you how you could answer. So peroral bleed after 2 hours, because 2 hours, not immediately. Okay. So after 2 hours, clots only present, no repeated swallowing, no frank blood. We could give hemostatic agent and observe. That's what I would do. I would observe the patient. I would place an adrenal soaked cotton ball over that particular place. I will give tranexamic acid for this patient. I will wait and watch. Okay. If still the patient is having frank blood and repeated swallowing, even after this particular exercise, I would do this. This is how I would answer. Okay. Because some are saying this could be the correct answer, but based on how the question is being asked, there is no frank blood, no repeated swallowing. For examination of if I see clots, I will not take up the patient for surgery. I have done this. We are doing this routinely. So only clots, you remove the clots, you place a hemostatic agent, you wait and watch. Okay, this could be the correct answer for me. Okay. Now, what is the difference between a tonsillitis and a peritonsillar abscess? The tonsillitis is always bilateral. Peritonsillar abscess is unilateral. What are types of tonsillitis? It's acute tonsillitis, chronic tonsillitis. So acute tonsillitis, you don't do surgery. Please don't do surgery. Like you in acute tonsillitis, congested tonsil, you would give IV antibiotic. The patient will be having severe trismus, severe congestion of tonsils. You should give IV antibiotics. Okay. So after that, chronic is repeated URI episode, repeated sore throat, repeated fever on and off. You should do a tonsillectomy in rose position. Okay. In peritonsillar abscess, it's a pus collection between superior constrictor muscle and capsular tonsil. You do IND as early as possible. After doing IND, it means that the tonsil is repeatedly getting infected. You don't wait and watch. After 6 weeks, you do a interval tonsillectomy. After 6 weeks, you do a interval tonsillectomy. Very high yield points I've kept. What is the other name for peritonsillar abscess? It is quinsy. It is quinsy. So, 9-year-old boy comes with complaints of right ear pain, difficulty mouth opening, painful swallowing, fever. Answer is quinsy. Answer is quinsy. So, unilateral mouth opening difficulty, no facial swelling, quinsy. Okay. So, the patient having pain over touching that particular area stimulates which nerve? So, this is glossopharyngeal nerve. So, pharynx is supplied by glossopharyngeal nerve. With this, let me introduce another topic from here. 9th and 10th nerve in ENT. So 9th and 10th nerve ENT, no one would have discussed topic in this fashion. So I have framed all the questions from all topics, all anatomy, and I'm framed it together. How the 9th and 10th nerve are especially important in ENT, and they have asked at least 4 questions from this particular topic. If you know the course of 9th nerve and 10th nerve correctly, so, sir, I haven't read about anatomy. I don't know anything about cranial nerves. Please read these 2 nerves course. If you read these 2 nerves course, you could answer hell a lot of MCQs over here. First, what is the 9th nerve? It's a glossopharyngeal nerve. What is the 10th nerve? It is vagus nerve. This 9th nerve, glossopharyngeal nerve, supplies the 3rd pharyngeal arch. 3rd arch. Then this vagus nerve is having 2 branches, superior laryngeal nerve, which is supplying the 4th arch. Then recurrent laryngeal nerve, which is supplying the 6th arch. Okay. So you just look into this picture. This pink color nerve is the vagus nerve. This vagus nerve is giving off the branch of, this is the superior laryngeal nerve, this is the recurrent laryngeal nerve, this is the recurrent laryngeal nerve, this is the superior laryngeal nerve. What you need to understand, the superior laryngeal nerve is given off at the level of neck itself, but this recurrent laryngeal nerve will come to the thorax. It recur around arch of aorta, left side, subclavian artery on the right side. So all are high yield points which I'm just telling. So arch question I have introduced you. Nerve supply of the arch also I have introduced you. The first arch nerve supply is mandibular nerve. The second arch nerve supply is facial nerve. So the pharyngeal arches, I have told you a lot of times in the class, very, very important topic that will give you a lot of MCQs. Okay. So left recurrent laryngeal nerve has a longer course because of which arch? Answer this question, please. Because of which arch? Because of sixth arch. Okay. So with this note, we could also solve recurrent referred otalgia. The glossary pharyngeal nerve, which is supplying the pharynx, is also supplying the ear in the form of Jacobson branch of tympanic branch, which is supplying the middle ear. Okay. This vagus nerve, which is supplying the larynx, is also supplying auricular branch or Arnold branch of vagus over the pinna and external artery canal. Whereas trigeminal nerve, which is supplying the face, is also supplying the pinna and external artery canal. So, if you are having a problem over the glossopharyngeal nerve, for example, tonsillitis or any oropharyngeal mass, that could be observed as a referred ear pain. For having some CL larynx, that could again be observed as a referred ear pain. So, the questions are asked in this fashion. Cough on scratching external canal. So, why there should be cough on scratching external canal? Which nerve is stimulated? Which nerve is having contact with the lungs also, intestine also? This is the previous slide. Pharynx, larynx, face. So glossopharyngeal supplies pharynx, vagus supplies larynx, then trigeminal supplies face. So this is Jacobson branch supplying the middle ear. This is Arnold branch, auriculotemporal branch, both are supplying pinna and external canal. Okay. So the answer is auricular branch of vagus. So vagus nerve on scratching the external canal can initiate the coughing, can initiate even heart response also. So that question can be answered. The NEET 2020 question. A 10-year-old boy presents with recurrent sore throat, difficulty in swallowing, ear pain, tonsils were enlarged, jugular digressed enlarged. What is the cause for ear pain? What is the cause for ear pain? So problem is present over the pharynx. The cause for ear pain is tympanic branch of glossopharyngeal nerve or Jacobson branch of glossopharyngeal nerve. After total thyroidectomy, anesthetist patient can be extubated, goes for cyanosis, respiratory distress. What is the nerve palsy? See, if the patient is having bilateral recurrent laryngeal nerve palsy, the patient will have stridor. The patient is having bilateral superior laryngeal nerve palsy. The patient will have severe aspiration. The patient is having bilateral both nerve palsy. The patient is having aspiration plus aphonia. Some small glimpse. The only palsy which is having stridor in a patient is can't be extubated, goes for cyanosis, bilateral recurrent laryngeal palsy stands. Unilateral and all will not cause any significant problems. Unilateral RLN, unilateral SLN, unilateral both now. Generally, you make dictum that some points are there, but generally conservative management. But patient is having cyanosis, respiratory distress after a total thyroidectomy. The surgeon would have injured the both recurrent laryngeal nerve. Sir, one recurrent laryngeal palsy, no problem. Only hosts of voice. Bilateral recurrent laryngeal palsy, most commonly seen after a total thyroidectomy. The answer is bilateral recurrent laryngeal palsy. Whoever says. So cyanosis, respiratory distress, the patient goes for stridor, bilateral recurrent laryngeal palsy. So vagus nerve. So this is also a branch of vagus nerve. With only 2 nerves, we could answer some 4 to 5 questions. Okay. So another important topic you answer this topic, if you look the topic in this way, you could solve a lot of MCQs. So differential diagnosis of infra-auricular swelling. So infra-auricular region, you'll be having a parotid gland, you'll be having a parotid node. Okay, you are having a temporomandibular joint. So these are the things you could see below the ear. Unilateral, sir. Unilateral, Dr. Suranjan, unilateral recurrent laryngeal palsy will never cause cyanosis, will never cause breathing difficulty. It will cause only mild hoarseness of voice. Okay. With the surgeon, I don't know, many are answering unilateral laryngeal palsy, but this question, bilateral is the answer. Unilateral laryngeal palsy, mild hoarse suffice. You will do only this Teflon injection or this Botox injection. But bilateral laryngeal palsy only, you'll be having the cyanosis, respiratory distress, and all the features. Because the opposite normal flow will be moving freely. So that will not cause respiratory distress. Both cards in paramedian question, both cards in paramedian question will only cause stridor. Okay. So differential diagnosis for infra-auricular swelling. So it could be a parotid tumor, it could be parotitis, it could be parotid abscess. So all are concerned with parotid only. So parotid tumor, you look for, can you see the earlobe lift? Parotitis, the pain can be due to the sensory supply. What is the sensory supply of parotid gland? Auriculotemporal nerve. This is the NEET-23 question. The parotid abscess can cause diffuse cellulitis kind of swelling. So all these three can be the conditions of intraoperative. What is the other condition? It could be a submandibular abscess, can also cause some parotid area swelling. So what is a Ludwig's angina? It is a submandibular space infection, mixed bacteria, occur mainly in immunocompromised individuals, very highly progressive. If it is highly progressive, it could need stridor. So stridor patients can need even tracheostomy. So Ludwig's angina can also be seen some swelling of infra-auricular region, not exactly submandibular. From infra-auricular swelling also can be seen in Ludwig's angina. The diffuse swelling can be seen like that. It's not exactly infra-auricular, but submandibular with diffuse swelling can look like an infra-auricular swelling. So infra-auricular swelling, you should definitely look into parotid tumor. They have asked a lot of questions in the last 2 years. Why? I don't know why. 50 years male, progressive swelling below the ear, it is definitely diagnosis of parotid tumor. Okay. 45 years male, progressive swelling, which structure is involved due to pain? The facial nerve, nothing to do with parotid gland. Okay, it is just bypassing the parotid gland. It will not compress the facial nerve and all. And also, sensory supply is not there. Okay, so what I would suggest in this particular question is, this lobule is lifted, the patient is having progressive swelling, it could be a parotitis, the patient will be having auriculotemporal nerve involvement. The involvement of the nerve, facial nerve or node or deep cervical fascia will not cause pain. Okay, yeah, in some books they have given investigator deep cervical fascia, but what I would suggest, see, this patient is having this enlargement of the pleomorphic adenoma causing pain over deep cervical fascia, I would not generally suggest. Okay, so some are saying investigator of deep cervical fascia can be the answer for this question, but as per the inputs given by my students, the patient is having severe ear pain, progressive swelling over the face. Okay, over the 2 years, it can be a pleomorphic adenoma also. But what causes pain? A pleomorphic adenoma will not be having a pain usually. Okay, the pain can be due to nerve involvement. That's what I would suggest. Okay, investigator of deep cervical fascia can be involved, but whether it will cause pain, I strongly differ from that. Okay, the pain can be only due to auriculotemporal nerve, because the auriculotemporal nerve is a post-ganglion supply from the otic ganglion. Is definitely a sensory supply also. It would definitely cause pain over the parotid region. That's what I would suggest. Okay, fine. So greater auricular nerve is responsible for pain. So greater auricular nerve is also carrying the sensory supply. Auriculotemporal nerve is also carrying the sensory supply. Okay, I don't deny that fact. Okay, greater auricular nerve is mainly for pinna. Greater auricular nerve mainly for pinna. The tumor getting enlarged will not cause a pain over the parotid region. Okay, what you are saying is correct only. Greater auricular nerve is through that area only. It's not exactly to the parotid region. The greater auricular nerve, this is the pinna, this is the parotid region. The greater auricular nerve goes like this. Okay, so this tumor compressing the greater auricular nerve is quite unlikely. That's what I would suggest. Okay, so for me, based on the reference done by me, auriculotemporal can be the correct answer. But that doesn't rule out the fact it could be. For me, deep cervical fascia, it looks like it can't be a reason for pain. That's what I would suggest. Okay, So the question itself, I don't know whether this is the same structure which I got from the students or not. But if they ask what is the reason for the pain, this can be the answer. Okay. 48-year male, non-tender swelling under earlobe, again a parotid swelling. Okay, 22 also one question is asked, 23 also one question is asked. So it's a parotid swelling. Differential diagnosis for lateral neck swelling. What are the differential diagnoses for lateral neck swelling? The first point is brachial cyst. So embryological remnant for second, third, or fourth economic cleft can cause brachial cyst. It can cause brachial cleft cyst over any ear. This is the first cleft cyst. This is second cleft cyst. The third cleft cyst. The first cleft cyst, if it breaks over the floor of external artery canal, this first brachial cleft cyst, it breaks over the floor of external artery canal, which is called as coloral fistula. It is called as coloral fistula. Okay. So brachial cleft cyst can be seen as a swelling over the sternocleidomastoid muscle. Swelling over the sternocleidomastoid muscle. It could be first. Now, what is the most common type of brachial cyst? Second type. Second type is most common type. Okay, fine. Embryological remnant. Next one is laryngocele. Laryngocele can also be seen lateral neck swelling. A small diverticulum from the ventricle of larynx through the saccule. Types of laryngocele are internal and external laryngocele. Clinical demonstrated by valsalva maneuver. Gurgling sound of swelling, rise sign. Symptomatic na you do a surgical excision. Symptomatic na you do a surgical excision. Fine. A retropharyngeal abscess which is having two types. One is pre-stellate, another one is retrostellate. Retrostellate compartment can also be seen lateral neck swelling. It will compress over the cranial nerves 9 and 11, sympathetic plexus and carotid artery can be involved. So very cautiously you should drainage. External drainage should be done on the neck. Whereas pre-stellate compartment, all drainage done on the intraoral route. External drainage, it is parapharyngeal abscess, retrostellate compartment. Okay, fine. What is the other DD for lateral neck swelling? Cystic hygroma. See, this is how the questions are framed. See, they will give a question, they give a swelling over a particular region, they are expecting the differential diagnosis from you people. So they may ask cystic hygroma also. Cystic hygroma, failure of communication between lymph and venous pathways seen in neonates. Okay, brilliantly transillumination will be positive. Sclerotherapy is a treatment for this particular patient. Cystic hygroma, it's a lymphatic and venous pathway miscommunication. What is the different diagnosis for midline neck swelling? So infrarectal swelling, parotid gland, lymphatic canina. Lateral neck swelling, brachial cyst, laryngocele, parapharyngeal abscess, retrostellate compartment, cystic hygroma. Midline neck swelling is very simple. It could be thyroid swelling, benign or malignant thyroid swelling. You should look for altered thyroid levels and hypo or hyperthyroid symptoms. It moves with degradation alone. If it moves with degradation, also with the protrusion of the tongue, very, very, very important point. It is called thyroglossal cyst. Then sometimes thyroglossal cyst can rupture itself. It causes midline opening with discharge in the midline. You excise along with the hyoid bone by cyst trunk operation. So a question, same question also asked. 50 years male, midline neck swelling, moves with protrusion of the tongue. It is thyroglossal cyst. Okay, midline neck swelling, moves with protrusion of the tongue. It's a thyroglossal cyst. Okay. So next topic, last but the one topic, X-ray neck and foreign body. They are asking lot of questions from this particular topic. So first, we look into two questions. First, we discuss about foreign body neck. Then we'll solve this MCQ. If you see a foreign body of neck, if it is a child, if it is an adult, the protocol varies. This child, if you have only suspicion, because in child you will not confirm the foreign body. The child will not talk, will not express itself. You do oral sweeping. What is oral sweeping? The parent will dip the fingers into the mouth to evacuate the foreign body. So in adult, no need of that. They know very well. So if it is confirmed now, if it is present over the neck with choking, the patient is having choking, repeated cough reflex. So this can be done in children. This can be done in adults. What is first one? Chest compression with fingers and back slap. Chest compression with fingers and back slap. What is this one? Heimlich maneuver. So in a restaurant, if suddenly some choking episode appears, repeated cough is happening, you do this for a children, this for an adult. Just compression with fingers with the back slap. Okay, fine. No sir, it has entered into a, it has settled down. The foreign body has settled down. The foreign body has settled down into the esophagus. If it has entered into the bronchus, both cases you plan for removal as well as possible. So in esophagus na, you do a rigid esophagoscopy and remove. In case of bronchus, you do a rigid bronchoscopy and remove. Why I am saying this? The flexible bronchoscopy and all only for diagnostic purpose. For therapeutic purpose, the best thing is rigid esophagoscopy, rigid bronchoscopy, and plan for removal. Plan for removal. Okay. So this is a settled foreign body over the esophagus or cricopharynx. Okay. If the foreign body is settled down and the patient is presenting without any breathing difficulty, it is esophagus. If the patient is presenting with breathing difficulty, you should suggest it's not, it can't be trachea, it could be a bronchus. Okay. Somewhere over here, if you see the foreign body, now the answer could be bronchus, not trachea. Why not trachea? Because trachea is a dynamic structure. The foreign body can't settle down over here. Bronchus is the stable structure. If the foreign body is seen over here, any peanut or any foreign body seen over there, now we could answer bronchus. But at the neck midline, it is only esophagus. You do a esophagoscopy and remove the foreign body. A young male suddenly develops choking episode while eating restaurant. What will you do? So what will you do? For both the questions, the answer is A only, na? Heimlich maneuver. Age group for back slap and chest compression. It's not exactly age group. So I would say it to be less than neonates and toddlers. Neonates and toddlers, you could do a chest compression. If the patient, if the age has something crossed over 4 years or 5 years, you could do a Heimlich. Okay, you could do a Heimlich. Can you see? So child present with same X-ray neck. The child present with biphasic stridor. X-ray image shows. What is this X-ray image? What is this sign? What is this X-ray image? What is the sign? It is steeple sign. It is a steeple sign seen in acute laryngotracheobronchitis, or otherwise called croup. So subacute viral infection caused by parainfluenza A and B is called as croup. It could cause X-ray sign of steeple sign or church top sign. Steeple sign or church top sign. So the steeple sign is due to subglottic accumulation of mucus plug, whereas acute epiglottitis can happen in unimmunized infants. So previously, Haemophilus influenza has more occurrence. Now pneumococcus is having more occurrence, more incidence. Lateral sign is thumbprint sign. The important difference is it is a lateral X-ray view. This is a anterior. It's a PA view. Okay, lateral view. This is a PA view. That's a difference. So this question based on X-ray neck image. Okay, X-ray neck image and the diseases we have seen them. The last topic, surgical field, important surgeries and their application. So we'll start from this question. Topical application of following drug is used in the treatment of. So answer this question. Please answer. What is the answer, please? So 2 minutes. We'll close that off. 2 minutes. We'll close it off. Okay, fine. Any answers, Pa? Yes. Fine. You may ask why I have kept this question, because this is a question they have asked because of mitomycin C used in subglottic stenosis. It is not seen in any other diseases. So what is the reason for subglottic stenosis? That is some surgical thing. Subglottic stenosis can be a cause of prolonged endotracheal intubation more than 7 days, or because of high tracheostomy. So what is high tracheostomy? If you want to know about high tracheostomy, you should know the usual site of tracheostomy. So what is the surgeries? What is the usual site of tracheostomy? It is second to third, fourth tracheal ring. But in some cases, I would suggest a high tracheostomy in case of suspicion of laryngeal carcinoma planned for surgery later. Why? Though I know that this high tracheostomy can cause subglottic stenosis or tracheal stenosis. Why I am doing this procedure? Because if the patient is having T3 or T4A CA larynx, be it supraglottis, glottis or subglottis, this patient can undergo a total laryngectomy. In total laryngectomy, I'm going to remove the larynx totally, thyroid gland totally, hyoid bone totally, and also first tracheal ring. So first tracheal ring, anyway, I'm going to sacrifice in this patient. So this patient, not only suspicion of laryngeal carcinoma, planned for surgery later. Not all tumors are undergoing the high tracheostomy concept. Only the tumors which are planning for surgery later. That surgery can be an indication for high tracheostomy. So now you know very well what is high tracheostomy. First ring is high tracheostomy. Why high tracheostomy done in laryngeal carcinoma? If the high tracheostomy is done in normal patient, it could cause subglottic stenosis. What is the treatment of subglottic stenosis? Mitomycin C. One concept, we have framed a lot of MCQs. Okay. Now with that note, we could solve some high-yield topics, not frank theory. High-yield topics between tracheostomy and total laryngectomy. Tracheostomy, transverse skin crease incision, second to fourth ring. Total laryngectomy, Gluck-Sorensen incision, like this. Indication for tracheostomy: respiratory obstruction, respiratory secretion, respiratory insufficiency. Respiratory obstruction means malignancy, foreign body laryngedema. Secretion means comatose or bulbar palsy. Respiratory insufficiency, prolonged intubation. Whereas in case of total laryngectomy, recurrent T3 lesion after chemo-RT or a T4A carcinoma larynx. Okay. This is the question they asked last time. This is a poster picture of tracheostomy alone. This is a poster picture of tracheostomy done in total laryngectomy. See here, the neck is intact. Here, neck is not there, completely compressed. So this is the picture they gave in the last exam. So 60 years male under difficult breathing. Which of the surgery was done? This is the image they gave in the last exam. So what procedure was done? This is not standard tracheostomy. This is a total laryngectomy with permanent tracheostomy. Okay. So this image, if there was given now, it is standard tracheostomy. This image was given in the picture. It is definitely case of total laryngectomy. Okay, fine. What are the complications between these two? Complications of tracheostomy can be hemorrhage, tube extrusion, tube block, subcutaneous emphysema, pneumothorax. Complication of total laryngectomy: pharyngeal fistula, chylus fistula, or wound necrosis. Okay. So which of the following is not indication for tracheostomy? This question was also a recent question. So airway obstruction, yes, it is a. Prolonged mechanical ventilation, yes, it is a reason. Pulmonary dilating in comatose bulbar, yes, it is indication. Upper airway assessment. We are not doing tracheostomy for upper airway assessment. Tracheostomy, upper airway assessment can be done only with laryngoscopy. Okay. So 32 slides. I have solved 37 MCQs only in a matter of some 60 to 70 minutes. Okay. So it's a high yield discussion. I will share this PDF with you. Okay. You could have a glance into it. You don't go anywhere for revision. So you are not allotting any time for ENT. You just read this PDF alone. You don't have time for ENT revision. Please read this alone. I have saved you some valuable time for you. Please keep reading this alone. So this will solve all your previous year questions thing, and all high yield topics has been covered. I have given a lot of points in this particular discussion. Yes, those who are having doubt, you could ask. So next session is there now. You could proceed for that session. Yeah, I will send you this. Whether they will upload it. 9th, 10th page. This is 9th, 10th page, doctor. This is the page you are asking for now. So next, sorry, I have occupied some of your time also. Video, yes, video definitely uploaded. Video will be uploaded. Then the PDF will also be uploaded. Nandini, 9th, 10th NV page. Can you tell some topic? Now pitch. Okay. 9th, 10th. No, sorry. No, NV, I didn't understand. This is 9th, 10th now page. Explain audiogram 1 second. Last point in this page, you don't understand. This one, Abba. The recurrent arch of aorta over left side is subclavian artery on the right side. Recurrent angina will be recurring around arch of aorta left side, subclavian artery right side. That's all. Audiometry, Dr. Vinod has asked. I will explain it. Any others? Anything else? Okay. Peritonsal abscess. Yeah, that was a great question, Dr. Aditya. Okay. Okay. Someone has asked the difference between the parapharyngeal abscess and the peritonsal abscess. Great question. It's actually potentially confusing topic. I will tell you. So, difference between the parapharyngeal abscess and the peritonsal abscess. Here, the concern is only pre-stellar compartment of the parapharyngeal abscess, not retrostellar. Okay. So, in both the things, here there will be medial bulging will be there. Here, enlarged tonsil. The tonsil will be enlarged. So, you could definitely find out the difference. So, medial bulging with normal looking tonsils. Here, tonsil will not be always infected. Here, enlarged tonsil with severe congestion of tonsils. And also, mouth opening less restricted, not severe. Restricted, less restricted. It is severe trismus will be here. So clinically, you could find out this one. But picture-wise, I can't demonstrate that here. So picture-wise, this quinsy you could easily find out. This peritonsal abscess, pre-stellar compartment, myself itself haven't seen such so many cases before. So clinically, medial bulging with normal-looking tonsil and mouth opening less restricted. These 2 points you could find, you could use it to differentiate between a peritonsal abscess and then parapharyngeal abscess, pre-stellar compartment, not retrostellar. Retrostellar nothing to do with tonsil. Retrostellar only neck swelling. Okay, pre-stellar only tonsil swelling. I hope it helps, Dr. Aditya. Then someone asked for audiogram repeat. I will tell audiogram repeat. Everyone kindly share the feedback. Okay, if possible, if you have time, kindly share this feedback. So audiogram, I will repeat. So you need to have 3 thumb rules in audiogram. So straight away, don't jump into diagnosis. First, you look whether the patient can also have normal audiogram also. In exam, if they give normal audiogram, you don't confuse yourself. First, you find whether it is a normal audiogram or an audiogram with hearing loss. So any curve, whether it is a bone conduction curve or a air conduction curve, if it is more than 25 decibel mark, there is hearing loss is present. Okay. Yes, I will send the PDF. I will send the PDF. Don't worry. So then, bone conduction curve alone, it is more than 25 decibel mark. It is sensory neural hearing loss is present. Then airborne gap more than 10 decibel, conductive loss less than 10 decibel, sensory neural hearing loss. Now you look in this picture. In this picture, first I'll apply more than 25 decibel mark. Yes, present, hearing loss is present. Then bone conduction curve is not more than 25 decibel mark. So which means that there is no sensory neural hearing loss. The third point, airborne gap more than 10 decibel. You look into this picture. So it's a clear-cut case of right-sided current hearing loss because right-sided red color marking will be there. Then the second curve, point number 1, both curves are more than 25 decibel mark. Hearing loss is present. The second one, the broken lines bone conduction curve is also more than 25 decibel mark. So sensory loss is present. The third point, airborne gap is less than 20 decibel. So sensory neural hearing loss is confirmed. Okay. This is a right-sided sensory neural hearing loss picture. Next one, 25 decibel mark, more than 25 decibel mark, hearing loss is present. The second one, the curve is more than 20 decibel mark in bone conduction. So it is sensory neural hearing loss is present. Third one, airborne gap is not less than 10 decibel. It is more than 10 decibel, which means that the patient is having both conductive loss and sensory loss. So we could confirm it is a right-sided mixed hearing loss. Did you understand, Dr. Dr. Vinod, do you understand? Anyways, I'll send you the PDF. You will understand it very well. Yes. Okay, that was a great session with you people. Thank you once again. How to tell right or left side? Which one you are asking for, Dr. Kavya? Are you there? Okay. An audiogram only, no. See, color code. First, to differentiate in audiogram between right and left, first use the color code. Red color for right side, blue color for left side. Okay. The second point is for right side, for air conduction, will be having right side 0 symbol, left side X symbol. Bone conduction for right side, you will use this symbol, left side uses this symbol. So based on symbols and color of the curve, you could find out whether it is right sided curve or left sided curve. Okay. Do you understand, Dr. Kavya? Based on color, first point. The second one is symbols. The symbols can be, if it is a O or 0, it is right sided air conduction. Yes, thank you. People are brilliant. It was a useful session for me also. Thank you so much. Thank you, Dr. SS. Seeing your message as last gives me immense happiness. Thank you again. See you all. Wish you all great success for exam. You all will come out very successfully. Thank you so much. Last page of PDF. Okay. Yes. Last part of the PDF. Last page of PDF. Na? Wait. Oh, last part of PDF. Na? Explain panliyo. Okay. Last part of PDF. This one you are asking for. Is it so? Okay. See, it's very important topic. I left actually. Thanks for asking. Tracheostomy tube can be a permanent tracheostomy tube or a temporary tracheostomy tube. Why permanent tracheostomy tube? The patient can have uncorrectable respiratory failure. The patient is having total laryngectomy. Our patient is having a CL larynx which is untreatable, palliative care. So you should give a permanent tracheostomy care for the patient. For permanent tracheostomy care, you should use a metal tube because metal tube will be having less secretion. Metal tube will be having less secretions. Okay. So metal tubes are two types. One is Fuller's, second one is Jackson. The Fuller's, as there is hole is there, voice can be produced. No hole, no voice in Jackson's tube. That is the difference between the Fuller's tracheostomy tube and the Jackson's tracheostomy tube. Temporary tracheostomy tube. The patient is on a prolonged ventilation. I could connect to the ventilator. For ventilator settings, metal tube is not prescribed. For ventilator settings, you should use only this kind of vortex tube or silicone tube. This is vortex tube without inner tube. This is Shiley's tube with inner tube. So synthetic tube with inner tube is called as Shiley's tube. They may ask this question also. Okay. So vortex without inner tube, Shiley's with inner tube. This Fuller's and Jackson with inner tube only. Okay. Okay. Understood? Okay. Once above page. This in the page தானே இந்த பேஜ் சொல்லவா இந்த பேஜ் சொல்லணும் அப்பதானே இந்த பேஜ் ஒண்ணுலப்பா இந்த क्वेश्चन தான் உங்களுக்கு புரியல நினைக்கிறேன் ஃபர்ஸ்ட் வந்து 60 years மேலே difficulty in swallowing, difficulty in breathing, change in voice. நல்லா பாத்துக்கோ swallowing difficulty இருக்கு, breathing difficulty இருக்கு, voice change இருக்கு. இது clear cut indication of CL larynx. இந்த பேஷண்ட்டுக்கு சர்ஜரி போயிருக்கு சரியா அந்த சர்ஜரி எந்த சர்ஜரி அந்த சர்ஜரி கண்டிப்பா வெறும் ட்ரெக்கியாஸ்டமி சர்ஜரியா இருக்காது ஓகேவா அண்ட் ஆல்சோ அதை காம்ப்ளிமெண்ட் பண்ற மாதிரி இமேஜும் இப்படி கொடுத்துருந்தாங்க. இமேஜ் இப்படி கொடுக்கல, இமேஜ் லாஸ்ட் நீட்ல வந்து இப்படி கொடுத்துருந்தாங்க. புரியுதா? இப்படி கொடுத்தாங்க அப்படின்னா which means that it's a permanent tracheostomy after total laryngectomy. ஸோ இங்க என்ன கேக்குறாங்க, இங்க tracheostomy பண்ணீங்களா இல்லையான்னு கேட்கல. என்ன கேக்குறாங்க, என்ன சர்ஜரி இந்த பேஷண்ட் பண்ணிருக்காங்க, டோட்டல் laryngectomy வித் tracheostoma கிரியேஷன், இப்படிதான் சொல்லணும். இது ஸ்டாண்டர்ட் tracheostomy கிடையாது, இது பெர்ஃபரன்ஸ் tracheostomy கிடையாது. ஆர் எல்ஸ் த ஆன்சர் tracheostomy ஆஃப்டர் laryngectomy கொடுத்தா கரெக்ட் ஆன்சரா இருந்திருக்கலாம். பட் இந்த tracheostomy இப்படிதான் இருக்கணும். டன் இன் கேஸ் ஆஃப் சம் ரெஸ்பிரேட்டரி இன்சஃபிஷியன்சியா ரெஸ்பிரேட்டரி செக்ரேஷன்ல பண்ணோம் இல்லையா, அது வந்து இந்த மாதிரி தான் இருந்திருக்குமே தவிர இந்த மாதிரி இருக்கக்கூடாது. ஸோ ஒன்னு இமேஜ் வச்சு இந்த ஆன்சர் சொல்லியிருக்கோம். ரெண்டாவது இந்த பேஷண்ட்டுக்கு சிஎல் தெளிவா தெரியுது, அண்டர் சர்ஜரின்னு சொல்லியிருக்காங்க. ஸோ டெஃபினெட்லி a total laryngectomy patient. Okay, partial laryngectomy என்றால் they will not give picture என்றால். Okay, partial laryngectomy will not be like this. Okay, இந்த கொஸ்டின் வந்து not an indication for the following device. இங்க பாத்துக்கோ, இண்டிகேஷன் ஃபார் tracheostomy ஒன்னு ரெஸ்பிரேட்டரி அப்ஸ்ட்ரக்ஷன். என்ன அப்ஸ்ட்ரக்ட் பண்ணலாம், டியூமர் அப்ஸ்ட்ரக்ட் பண்ணலாம், ஃபாரின் பாடி லாரிஞ்சல் எடிமா இன் கேஸ் ஆஃப் ஹைப்பர்சென்சிட்டிவ் ரியாக்ஷன் ஆர் ரெஸ்பிரேட்டரி செக்ரீஷன். அந்த பேஷண்ட்டுக்கு வந்து ஸ்வாலோ பண்ண முடியல, அங்க அந்த லாரிங்ஸ் அந்த 9th and 9th வந்து சரியா வந்து ஹையர்லேயே வந்து அடி வாங்கிடுச்சு. ஸோ கோமட்டோஸ் ஆர் பல்பர் பால்சி இல்ல ரெஸ்பிரேட்டரி இன்சஃபிஷியன்சி ப்ரொலாங்டு ரெஸ்பிரேட்டரி ஃபெயிலியர். பேஷண்ட்டுக்கு வந்து ஒரு பாய்சனிங் கேஸ், அந்த பேஷண்ட் ரெக்கவர் ஆகிறதுக்கு 1 month ஆகும்னு சொல்லிட்டு இன்டென்சிவ் சொல்றாங்க. ஸோ 1 month வரைக்கும் எண்டோட்ரிகல் டியூப்ல வந்து கொடுக்க கூடாது. ஸோ 7 days 6 days தாண்டிஸ்னாலே tracheostomy டியூப் கொடுத்து அந்த பேஷண்ட் ரெக்கவர் ஆகிற வரைக்கும் அந்த பேஷண்ட் tracheostomy வச்சுக்கோங்க. ஸோ இது பல்மனரி டாய்லெட்டிங் ரெஸ்பிரேட்டரி செக்ரேஷன் கேட்டகரியில வருதா, அப்பர் ஏர்வே அப்ஸ்ட்ரக்ஷன் ரெஸ்பிரேட்டரி அப்ஸ்ட்ரக்ஷன் ஆர் ஃபாரின் பாடி அந்த கேட்டகரியில வருதா, ப்ரொலாங் மெட்ரிகா மெக்கானிக் வென்டிலேஷன் ரெஸ்பிரேட்டரி இன்சஃபிஷியன்சி கேட்டகரி வருதா. ஸோ இது மூணுமே நம்ம ஏற்கனவே இண்டிகேஷன்ல பார்த்துருக்கோம். அப்பர் ஏர்வே அசஸ்மெண்ட், ஸோ ஏர்வே பாக்குறதுக்கு ஓட்ட போட்டு தான் பாப்பியா, அப்படிலாம் பார்க்க கூடாது. ஏர்வே பார்க்கணும் அப்படின்னா மவுத் வழியா ஒரு ஃபைபர் ஆப்டிக் ஸ்கோப் போட்டு பார்க்கணும், இல்ல லெரிங்கோஸ்கோப் போட்டு பார்க்கணும். ஸோ ஒரு ஏர்வே அசஸ்மெண்ட் பண்ணோம் அப்படின்னா லெரிங்கோஸ்கோப் வழியா பார்க்கணுமே தவிர தொண்டை வழியா ஓட்ட போட்டு பார்க்க கூடாது. புரியுதா? ஸோ அதான் வந்து டிஃபரன்ஸ். ஓகேவா? ஃபைனா கடை அடிக்கலாமா? ஓகே, தேங்க்யூ.